All right, thank you so much, Dr. Liu, and hi everybody. I'm so excited to announce and introduce our next speaker, Dr. Jason Harper. Briefly, Dr. Jason Harper runs the Harborview Medical Center IBD clinic, seeing a diverse panel of individuals living with Crohn's disease and ulcerative colitis. He's a graduate of Columbia University for Medical School and did his internal medicine and GI training at UW, where he's currently an associate clinical professor. He also completed training at the University of Arizona in integrative medicine and at Cedars-Sinai in medical nutritional therapy for IBD. So without further ado, I'm going to turn it over to Dr. Harper. Feel free to share your slides. I'll be monitoring our chat and questions, and we'll keep a few minutes at the end for questions.
Perfect. First and foremost, before I get started, could I just get a thumbs up sound check? Can everybody hear me okay? I am on my AirPods, and sometimes if just feel free to let me know if anybody's having trouble hearing me.
Perfect.
So I will go ahead and get started. And I hope this actually segues somewhat nicely, perhaps from the conversation that you all were just having, though that wasn't necessarily by design. When I was approached to come up with a talk around the inpatient management of individuals with inflammatory bowel disease, I decided to focus on a couple of arenas that, as a GI consultant, though I'll preface this by saying I think these are arenas we should have more to say about, more caring for individuals living with Crohn's disease and UC, who, as is the nature of their conditions, it is not uncommon for them to make their way to needing inpatient care at some point in their disease process. The arenas we don't comment on often enough that are so integral in their both in and outpatient care are managing pain. That is often an attendant part of their conditions. And then if we have some time, because it's a hobby horse of mine, I'd love to talk about how dietary therapy can be used, including in the inpatient management of active inflammatory bowel disease. I do not have any pertinent disclosures for this presentation. And like I said, there's kind of two components to this, though I'll probably, if time is short, if I'm running a little long, I'd love to focus more on item number one, and then we might go a little bit rapid fire to save time for questions about nutritional therapy. So first and foremost, why is this something worth knowing about? Why do I find this topic interesting? Couple of background points. First and foremost is that, as I said at the outset, pain in various expressed forms is a very common symptom that goes hand in hand with active inflammatory bowel disease. And we know that no matter how you slice it, in pretty much every IBD specific study that looks at outcomes, the use, short or long term, of opiate analgesics is consistently associated with essentially every bad outcome you want to envision in this patient population. Increased infections, increased mortality, increased hospitalization, longer length of stay, higher need for surgery. This goes above and beyond any sort of proxy or surrogate marker for individuals who just happen to have more severe disease, nor is it just track with other comorbidities that might go hand in hand with sorry, can you guys see it again okay?
Yes, we can see your presentation.
Okay. This doesn't just track with common comorbidities that might predict opiate use. There actually appears to be, even after adjustment for those factors, an intrinsically negative effect of opiate analgesics in the disease course of inflammatory bowel disease. And there's biological plausibility for this. In animal models, excessive activation of the endogenous opiate receptors in the gut seems to facilitate an inflammatory milieu. So again, there may actually be a directly negative effect that these agents have in individuals with inflammatory bowel disease. We also know that their use is very high among this patient population. Studies suggest that upwards of almost half of all patients who end up hospitalized for their condition for inflammatory bowel disease will leave with a prescription for opiate analgesics. And as I mentioned beforehand, among the many other variables that track with this, it includes increased rate of readmission to the hospital after index hospitalization. So through the next several slides, I'd like to talk about some really neat studies in this space. And again, there's nothing that I'm going to present to you that I think is reinventing the wheel here. This is really a continuation. It's more IBD specific, but it's a continuation of a robust body of literature around the efficacy of assertive pain management protocols that lean heavily on non-opioid analgesics to achieve their effects. It's extrapolated into the IBD space, but I think obviously you can take this and run with it in so much as that these in themselves are some of the algorithms I'll show you are derivatives that stem from things like early recovery after surgery protocols. So again, not really reinventing the wheel here. The other thing that I love about some of these studies is they're such low hanging fruit. They're sort of shovel ready products. This is an example of one. So this was a study that was done out of the University of Pennsylvania, and it was a pre and post intervention study that looked at several targeted interventions to try to reduce opiate analgesic use among individuals with inflammatory bowel disease. What I love about this study, when I say low-hanging fruit, is that this was not, there was no prescriptive element to this study. This was purely, as you'll see, the interventions that they offered were essentially educational, optional, and they put this information out there. And then they looked at what happened in individuals admitted to their hospital system with a primary diagnosis of inflammatory bowel disease before and after this intervention, using their 6 months prior as their pre-intervention control. The 4 things that they did. The first is that they expanded access and their inpatient formulary to the use of intravenous acetaminophen for individuals with inflammatory bowel disease. Prior to this study, that was restricted to postoperative individuals who were not taking anything by mouth. In all of the GI consult notes for patients with inflammatory bowel disease, they had the fellows put in a dot phrase that kind of, here's some of the data around how opiates are negative. Here's some suggestions. Let's point you towards some resources. They published a suggested algorithm for pain management to their departmental intranet. And then through some internal messaging system, anytime a house staff or hospitalist team was admitting somebody with a primary diagnosis of inflammatory bowel disease, they got some kind of an alert that directed them to these resources if they wanted to avail themselves of it. I know that it's a little, the font is a little small, so I'll kind of give you the highlights here. This was the suggested algorithm that was published to their departmental intranet. And really there's just, again, I want to just highlight a couple of key points here relating back to the theme that what they were suggesting is derivations of the theme, both within some of the studies that I'll talk about subsequently, but that were also being borrowed liberally from other assertive non-opiate pain management pathways that have been described for other conditions, including postoperatively. So first and foremost, again, some highlights. They really leaned on assertive liberal use of scheduled acetaminophen, oral ideally, if they could take that route. They made multiple suggestions around various families of non-opiate analgesics, again, to use pretty liberally in addition to acetaminophen, thinking things like neuromodulators, muscle relaxants, antispasmodics, and we'll come back to this, also COX-2 inhibitors for this patient population. If these interventions proved insufficient, the opiate of choice that they recommended, and again, we can quibble with this depending on the nature of the patient population you're taking care of, but keeping in mind that individuals with IBD, broadly speaking, tend to be younger, tend to generally have not a ton of other medical comorbidities, including liver disease or polypharmacy that would make this agent more problematic, but they suggested tramadol. And then if that proved insufficient, still limiting oneself to lower potency oral opiate analgesics, thinking more like hydrocodone, for instance. And then if and only if those interventions proved insufficient and somebody had to escalate to using intravenous opiates, they also made a recommendation that at that point, acute pain services get involved. The demographics of this study were very representative of what I would say, entails a high volume tertiary IBD center. And I think, again, generally representative of the type of individuals with inflammatory bowel disease that we might see at our institutions who end up needing to be hospitalized. That is to say that these were folks with very active disease in many cases. These were folks on advanced therapy, high rate of prior disease-associated complication. I will also highlight that a third of these individuals, both before and after this intervention, were individuals who on their medication reconciliation had opiates listed on their home medication. Doesn't necessarily mean that they were taking them, but these were individuals who, I think suffice to say, had seen opiates at some point in their lifetime beforehand. And here's what happened after this intervention. And again, I want to point out this was not prescriptive. This was just here's some data, here's some thoughts, take this and run with it. And what they found were substantial reductions in some important things or improvements in some important things. First and foremost, and I personally find these numbers encouraging on their face, they found an almost 15% absolute reduction in any intravenous opiates being given. They found not statistically significant, but modest reductions in any opiates, including oral opiates being given. They found an uptick in the use of intravenous Tylenol or acetaminophen, excuse me, because they opened access to that. But the real kicker, in my mind, is before and after this intervention, they saw a 50% reduction in 30-day readmission rate in this population. Again, across the board, even when opiates were being used after this intervention, substantially less opiates were being given. They found a 2-day drop in length of stay after this intervention. And they found that across the board, average pain scores were unchanged in this before and after intervention. People were reporting similar amounts of pain, albeit less in a good sense, with substantially less opiates being used, lower lengths of stay, and less bounce backs. And this is going to be a recurring theme in some of these other studies. This is another study out of the University of Illinois, Chicago. This is even less intervention than the Penn study. This was essentially providing education to house staff. I envisioned through some kind of morning report style presentation, but coming back to these central themes of education around the importance of opiate minimization in this patient population. So this was there were suggestions, and you'll see a lot of dovetailing with what had been suggested by the Penn approach. And the highlights are, again, liberal use of scheduled acetaminophen, liberal use of antispasmodics, suggestion to get pain services involved earlier. I will highlight, because I think it's something that I certainly pass on to our trainees over and over again, treat the underlying condition. If the pain is being driven by inadequate control of the underlying disease, treat the underlying disease. Don't just, as important as it is to treat the symptoms, treat the process. And again, somewhat similar recommendations around choice of agents, steering people toward lower potency agents, if at all possible, before escalating to more potent opiates. In terms of the demographics of this study, which was a much smaller study, but similar study design to the Penn study, they instituted this educational intervention, and then they did retrospective chart review to see kind of what happened to those individuals before and after the intervention who were admitted with a primary diagnosis of inflammatory bowel disease. One highlight compared to the previous study, there was less overall pre-hospitalization opiate exposure in this group. But again, I'd say fairly representative of most of what we see in individuals with IBD who end up requiring hospitalization. And in a very similar fashion to the Penn study, they showed substantial decreases in both the administration of any opiates whatsoever after the intervention, and let alone when opiates were being used, marked decreases in the total amount that were being given. Again, similar theme. Pain scores were no different on average before and after their intervention. And even with much smaller numbers, which to me reflects the potential potency of an intervention like this, they still saw meaningful reductions in length of stay and substantial reduction in readmission rate after institution of what was essentially a shock, so to speak, for the house staff around the importance of trying as best they could to peel back opiates in this population. This doesn't just work in hospitalized patients. This has been studied in the emergency department setting. And again, sort of coming back to a central theme, benefits were seen with educational intervention for providers in the emergency department. This was a small study that was published in abstract form a couple of years ago. And again, the interventions were not prescriptive, they were purely educational. And in this relatively small study, the rate of opiates being prescribed or given in the emergency department for these folks fell by a third. Rate of GI consultation, not virus, but I'm sure my colleagues might appreciate that, fell by a little bit. And there was a non-statistically significant reduction in which these folks ended up needing to be admitted to the hospital with less opiates being given in the ER. And again, people did not report any higher degree of pain after peeling back the opiates. The final study that I want to present along these lines is interesting on its face because this was a proscriptive study. This was a study done out of Cedars that looked at this was a randomized study of individuals admitted to their hospital with inflammatory bowel disease being randomized to one of two pain management strategies that I will elaborate on. Now, there's this study I present purely for interest's sake because there's obviously there's a lot of issues with this study, and it's a hard type of study to do for understandable reasons. First and foremost, obviously, this was not a blinded study. This was also, their recruitment was exceedingly slow for multiple reasons, chief among which, well, two. One was just refusal to participate. And also, they adopted a very liberal exclusion criteria such that in the opinion of the investigators, if somebody with inflammatory bowel disease was being admitted and there was any chance that they could need surgery imminently during that admission, they were excluded from participation. So the generalizability of who would actually want to participate in a study like this is, there's questions one could have with that. It ended up being a very small study. But why I like it nonetheless is, again, the idea of putting forward some interesting thoughts around how we do pain management in these individuals. So here was for folks that in this study were randomized to the algorithm, were randomized to the pathway approach. Based upon on a visual analog scale, their pain scores, they were tracked into one of several SMART sets, and this could change based on changes in their pain on reassessment. The highlights, seeing a theme here, right? Scheduled acetaminophen. And then for higher degrees of relative pain, scheduled gabapentin, scheduled celecoxib. And interestingly, and we'll come back to this, the use of benzodiazepines as a PRN here in lieu of opiates as a PRN. When folks had breakthrough pain on the algorithm, they were to start off with oral tramadol, and only then, if all else proved insufficient, IV morphine was the rescue. And then the standard pathway was just at the discretion of the treating medicine service. Small study. So what did they find? By and large, people randomized to the pathway versus standard of care had similar pain scores by the day. There was numeric trends across the board for lower overall pain scores in the intervention group, but certainly not higher pain scores by any stretch of the imagination. They also found substantially less opiate usage in the individuals who were randomized to the proactive pathway. They had these folks wear actimeters, which I thought was kind of interesting in its own right. This data was a little all over the place. Sleep quality was similar between the two groups, but they did find that in the group that had been randomized to the algorithmic pathway of pain control, they found that essentially they were getting out of bed more and they were recording more steps in the hospital in the proactive intervention group. So there's a couple of things that I think, before moving on, that are embedded in this that I think are worth pointing out in the way that this really delves into, I think, a lot of the physiology and psychology of pain management too. And so a couple of highlights that stand out to me in working with this patient population. One thing that I do find, and I found this to be anecdotally helpful, is I go back to the benzo question. So a lot of folks with inflammatory bowel disease, based on the natural history of the condition, if they are being hospitalized, it's quite possible, if not probable, that is not their first hospitalization. And so working with individuals who may have developed these conditions when they're very young and have had a number of experiences, negative included, with the idea of being hospitalized and what happens when they're in hospitals, many of these folks carry a certain degree of medical trauma associated with their history. And so the inpatient setting can be a very re-traumatizing experience for these individuals. And we know, I don't think it's controversial at all to say, that anxiety, recrudescent anxiety, can substantially increase concurrent pain. And when we lock people into a, shall I say, fairly bog standard pain pathway in the hospital, which usually consists of PRNs, and PRNs based on visual analog scores for pain that pretty much say, mild pain, you get Tylenol; moderate pain, you get oxycodone; severe pain, you get intravenous hydromorphone. I think the psychology of that is that if you are in pain and concerned that maybe you've had experiences in the past where your pain has not been appropriately treated, you are now plugged into something where there's a transactional element for how you have to get pain relief. It's on a schedule, and it's on a schedule where you have to ask for the pain relief, versus a scenario where we reassure people right off the bat, we are going to take your pain seriously. We have a system in place to proactively manage it. It's always easier to tell somebody you can decline a medication than you have to ask for this, and take that somewhat transactional element of it out. I want to make a couple of specific points about certain things that often come up in pain management for individuals with inflammatory bowel disease. Here's a big one: NSAIDs and IBD. Because historically, it has been felt, and often the guidance that is given is that individuals with inflammatory bowel disease should forswear entirely the use of nonsteroidal anti-inflammatory drugs, for fear that these medications may increase their risk of complication related to their condition. Um, it turns out, like a lot of things that we sort of talk about a lot as though they are should be accepted by fiat, the data around this is actually not as clear cut. There have been studies, including prospective studies, that suggest that extended use of regular non-selective NSAIDs may increase the risk of IBD flare. I refer chiefly to one study that was done almost 20 years ago, where they put people with UC on 4 weeks of various NSAIDs, and they did see during that period of time that there was a measurable number of people that had a potential flare in their ulcerative colitis in doing this. That being said, there have been other studies that have tried to look more retrospectively at the timing of IBD flare in relationship to receipt of a prescription for an NSAID. That data is a lot murkier. There is prospective data that at least short-term usage of celecoxib appears to be safe in individuals with ulcerative colitis. This is still a question to which we lack for a lot of concrete data upon which to make recommendations. But we do have to be cautious, and I think it gets to the central problem that when we wholesale limit any and all access to a class of non-opiate analgesics for individuals, it vis-a-vis makes it very easy that if something like acetaminophen is not working for somebody, we feel like we run out of options, and I think we, faster than we should, escalate to an opiate analgesic. So, what are my takeaways, and what would I emphasize around this is that, generally speaking, I think this is a topic that is still ripe for more studies, more changes, more ways to approach this, but that it is very doable to institute protocols at our institutions in working with people who are admitted with inflammatory bowel disease. And like I said, I think this generalizes in a lot of different ways, but my wheelhouse is inflammatory bowel disease, to minimize the need for opiate analgesics to be given to these individuals. And when doing so, to be more conscientious about how we're doing that. There are some things that if you're working in obviously with a more medically complicated patient population, that one does need to be careful if one is just going to wholesale implement some of these strategies. Things like scheduling acetaminophen, one has to be a little bit careful of, depending on the patient population. We've certainly seen at my institution, when I wear my other hat as an inpatient GI consultant on the liver service, we have from time to time seen people develop inpatient acetaminophen-associated liver injury because of over-judicious use of scheduled acetaminophen, especially in folks that are older, malnourished, or with pre-existing liver disease. In a similar sense, the enthusiasm for tramadol in some of these protocols, your mileage may vary if you have folks, again, with pre-existing liver disease or who are on polypharmacy, where there could be interactions with tramadol based on its serotonergic effects. And as I said earlier, and I can't emphasize this enough, analgesia in general is one of the arenas in which placebo effect is our best friend. Very high placebo responses in the effects of analgesia, and we should lean into that. And so ways we can optimize placebo response is by minimizing negative expectation bias around the receipt of analgesia, and also making sure that the best that we can do, we separate out the affective component of pain and treat that as well, versus leaning on opiates to treat affective pain. Now I'd like to segue into some studies around inpatient nutritional management and IBD. As mentioned, this is something I'm very interested in. And it's a common refrain among my patients living with these conditions is questions around their diet and nutrition. And there's There's a lot to be said in a different context. I could go on and on about this, but I wanted to, again, bring it to some pearls and bon mots for inpatient management of this. So first and foremost, again, why is this important? Malnutrition is very common among people living with inflammatory bowel disease. And I think in my field, we recognize that we don't recognize it well enough. Malnutrition, when it is present, really regardless of the exact definition that you use for it, depending on the various clinical scoring systems for this, the presence of malnutrition is a risk factor for adverse outcomes in individuals with inflammatory bowel disease. And in particular, much like with the analgesia literature that I presented, we can piggyback off of already existing literature in, for instance, the surgical literature around the benefits of nutritional therapy, even short-term nutritional therapy. We can really piggyback a lot of those benefits to the medical care of individuals with inflammatory bowel disease. I'd like to lead with an all too common issue. This is a neat study and an all too common issue when you're taking care of folks whose primary reason for admission, in this case, it's ulcerative colitis, but again, you could extrapolate this to a lot of other GI disorders. And this was a study that was a retrospective review, single center, of the appropriate versus inappropriate use of NPO orders. In this case, it was for individuals who were admitted to the hospital with a primary diagnosis of ulcerative colitis as the reason for their admission. Their definitions in this study of appropriate versus inappropriate use of NPO, as well as clear liquid diet, I think it goes without saying that a clear liquid diet is an NPO order for all practical purposes. Clear liquid diets are intensely hypocaloric, and even if you're including, the isolated clear liquid protein supplements, these are NPO orders for all practical purposes. They were considered justified if it was like somebody had a procedure scheduled in an imminent time frame that would warrant an NPO order. Acute pancreatitis is, I would actually argue, not an appropriate NPO order most of the time, but we'll roll with it. Certainly toxic megacolon is an appropriate NPO order, or people who just could not take PO because of recalcitrant symptoms. If they could not find any of these particular rationales, then it was considered an unjustified NPO order if the person was not otherwise receiving enteral nutrition or TPN. They reviewed 180 admissions for individuals who were admitted with a primary diagnosis of ulcerative colitis, and had to have at least a 2-day length of stay to be included in their review. And they found a total of 200, among these 180 admissions, 252 individual NPO orders were written for these folks. And on intensive chart review, they found that upwards of 50% of these orders, they really couldn't find any obvious reason why the person had been made NPO. In the individuals who had an inappropriate NPO order, the average duration of period of time that they were not getting any meaningful nutrition was 3 days. The most common reason they could come up with for these purported unjustified NPO orders was that that's just what was ordered at the day of admission. They just were put on an NPO order from the ER, and people didn't adjust that, again, on average for up to 3 days. And this was not even necessarily an anticipation of, well, maybe they'll get scoped the next day. Folks that were on these prolonged inappropriate NPO order sets were actually less likely to undergo an endoscopy during their admission than the people who were not inappropriately kept NPO. Although, again, based on their criteria, that makes a certain amount of sense. I might gloss over this one a little bit, but I find it so interesting, so I guess bear with me. This was a study of exclusive enteral nutrition in individuals with complicated Crohn's disease. So backstory here, a little bit of a backstory. Exclusive enteral nutrition, which as its name implies, refers to people being put on an all liquid diet that is nutritionally complete as primary therapy for their Crohn's disease is an established standard of care treatment for children and adolescents with Crohn's disease. Exclusive enteral nutrition for periods of generally between 4 to 8 weeks has equivalent anti-inflammatory benefit as corticosteroids in the immediate treatment of pediatric Crohn's disease, with substantially higher rates of healing the lining of the bowel. In much of the world, again, this is kind of top-line therapy for new presentations of severe Crohn's disease in the pediatric population. In the United States, uptake is demonstrably less compared to the use of corticosteroids. There is some relevant data in adults, too, that this can be potentially helpful, although compared to the pediatric literature base, the data in adults is a lot less. And I'm happy to allow, if anybody has questions about that, we can go over it, but just kind of we'll take it on faith for right now. But this was an interesting study done out of a hospital in Taiwan that was a retrospective single center observational trial of 12 weeks of exclusive enteral nutrition that was given through an NG tube, I might add too. So this can really only be done, kind of alluding back to why this may not work as well in adults, is quite frankly, a lot of adults, for totally understandable reasons, this is not something that they would be keen to try. I mean, imagine going 3 months, taking literally no food by mouth and just being fed through an NG tube. But that's what these folks agreed to do. And when I say with B2, B3 Crohn's disease, what I mean is that these were individuals with complicated Crohn's disease, primarily fistulizing Crohn's. These were people with abscesses. These were people with draining enterocutaneous fistulas. This was more than just purely inflammatory Crohn's. B2 Crohn's disease refers to fibrostenotic Crohn's disease strictures. In this observational study, these folks were getting no other medical treatment besides EEN. No steroids, no biologics, nothing. The only exception to that was that individuals who had an intra-abdominal abscess were allowed to get antibiotics afterwards. Otherwise, the exclusive therapy was tube feeding for 12 weeks. They recruited 41 individuals to participate in this study. Like I said, most of whom had severe internal complex fistulizing disease. These are sick individuals. And what did they find? Well, as a lot of studies of EEN show, first and foremost, you get improvement in biomarkers. And this has been demonstrated in adults as it has in kids. CRPs go down, albumin tends to increase, hemoglobins increase. The biomarkers that reflect disease activity in Crohn's disease often tend to improve with this therapy. Plus, of course, if you are substantively providing good nutrition for folks, this is also going to improve their nutritional parameters too. But more intriguingly, and this is a little bit of a busy slide, but more intriguingly, in those folks who underwent paired endoscopic procedures before and after the initiation of EEN, they saw, not universally, but directionally in a lot of folks, they saw substantive improvement in internal inflammation as assessed by standard endoscopic scores in individuals who are on EEN. In many ways, this is the meat and potatoes of what we do in inflammatory bowel disease nowadays. Is as important as it is, we want our patients to feel better, but we really adjudicate the success of our therapies through, are they achieving mucosal healing? AKA, are they healing their ulcers? Are they healing all the luminal signs of inflammation? As studies like this like to do, these are cherry-picked photos, but fascinating nonetheless, because you see these were some examples of pre and post endoscopic images of people whose sole medical therapy was tube feeding, showing dramatic improvements in the inflammatory findings before and after this intervention. In fact, with this intervention, most of these people, at least during the study period of time, avoided surgery, which is usually where the end destination for a lot of these folks with B2, B3 Crohn's disease. They saw closure of enterocutaneous fistulas in a number of folks. Again, small numbers, but like those are better numbers than what we would expect with medical therapy alone. And they saw decreases in bowel wall thickness that were not statistically significant in the individuals who had stenotic disease segments. This is a meta-analysis that was published fairly recently of exclusive enteral nutrition in individuals with Crohn's disease who were undergoing planned intestinal surgery. So this to me is an arena where this therapy can shine. 20 studies were included. As meta-analyses tend to be, and I have many personal thoughts about meta-analysis that I'll keep to myself, but I'm choosing to include one, so take that as such. Very heterogeneous studies, in particular in regard to the nutritional therapy protocols that were being used in these studies were quite variable in terms of duration, though all of them included this aspect of exclusive enteral nutrition. They also separately did an analysis of those studies that had description of individuals on TPN as sort of a separate arm of analysis. What they found was that directionally there were significant reductions in postoperative complications in those individuals who were assigned to EEN versus usual diet or TPN before surgery. Intra-abdominal septic complications here really is alluding to occurrence of anastomotic leak in this population. And again, I think if we take this at face value that this is true, There's plausible mechanisms for this, twofold. One is that you're supporting people's nutrition first and foremost. Malnutrition is definitely a risk factor for anastomotic leak in this patient population. The second reason might have to do with the intrinsic anti-inflammatory effects of this therapy. They also found, I'm going to stop here for a second. Just can I get a thumbs up that we're all still good? You guys can hear me okay? I get a little nervous sometimes. Okay, get a little nervous sometimes. All right. They also found, not quite as much, but they found lower rates of surgical site infections in the groups that were getting EEN. I'm going to kind of skip over this. There weren't really any other parameters that differed between the groups in terms of the length of the surgery, the length of resected bowel, length of stay in the hospital. I will note, actually, before moving on, though, that in the subset analysis that they did of TPN as the nutritional intervention of choice compared to ad libitum diet, TPN did not lead to reductions in anastomotic leak or surgical site infections in the same way. TPN is better than nothing. If you have the option of somebody not eating at all versus TPN, obviously TPN is better than nothing at all. But suffice it to say, using the gut is always fundamentally better than not using the gut unless you have literally no other choice. The final study that I'll end on here, that again, I think is so interesting from a conceptual standpoint, is the use of exclusive enteral nutrition in acute severe ulcerative colitis. Unlike the case in Crohn's disease, the data for EEN in UC has generally tended to be more underwhelming. So it's not generally used as a primary therapy for individuals with UC. However, this was a study, pardon me, that looked at the adjuvant use of EEN as medical therapy for individuals with UC who are also being treated with standard medical approaches versus ad libitum diet. So this was a single center study of people admitted with acute severe UC defined by standard criteria that we all use to make this designation. And in both arms of the study, everybody got top line, very conventional management of this. They got IV corticosteroids for a set period of time. And if they were not responding, then again, all very standard, then they would proceed on to some form of salvage therapy. It turned out in the study that that was infliximab exclusively, like done according to what we all do. This is bog standard acute severe UC management. The intervention was either ad libitum oral diet or people being willing to be on 7 days of exclusive oral nutrition. They used the semi-elemental formula for this study. They under-recruited. It's a hard study to recruit for, and they also ran into COVID during study recruitment. This gets a little busy. I will summarize this by saying a reasonably representative acute severe UC population. These are pretty sick folks. I would say this is a pretty representative patient population for an acute severe UC study that you might see in other contexts. What do they find? So in their intention to treat analysis, they came very close, extraordinarily close with relatively limited numbers to showing a benefit of EEN in preventing steroid failure, AKA less need to move on to a salvage therapy like infliximab during the hospital stay. They also found reduction in length of stay by about 3 days in the EEN group. They did have a fair number of dropouts in the EEN group that were primarily due to intolerance to the formula. In their per protocol analysis, they were able to show a steroid sparing effect or advanced therapy sparing effect, I should say, to the use of EEN. What they showed, and again, this is important in so much as that these are the numbers that we often track in this population to determine are they responding to the therapy that they're being given. They found that in the group that had been randomized to EEN, there were improvements in serum albumin, faster reductions in C-reactive protein, greater reductions in fecal calprotectin with the EEN approach. Overall, both groups were eating similar amounts. In the EEN group, caloric intake was calculated, and they were also tracking how much of the formula people were drinking. In the ad libitum group, they were doing calorie counts, and in both arms, the total amount of kilocalories and protein intake were similar. As I mentioned, they had a fair amount of dropout in the EEN group because of intolerance to the formula. If anybody has any questions, we can go over that. There's tips and tricks to getting people to do this, but it's a hard sell for a lot of folks for completely understandable reasons. They did find overall in the group that had been randomized to EEN, they found lower composite rates over 6 months of readmission to the hospital or need for colectomy. They gloss over the microbiome stuff. So my take home from these studies are that first and foremost, we know malnutrition is common in folks with inflammatory bowel disease, especially when they're admitted to the hospital. And again, harkening back to the analgesia component of this, I think there's a lot of things we can proactively do differently before immediately jumping to other solutions, chiefly TPN. I mean, as a guy, TPN to me is always it's an option of last resort. It should not be the option of first resort for people that are not meeting their nutritional intake. And there's so many situations in which, even if it may not be easy up front, you can get people to use their intestines. Like if the intestines work, we should always try to use those first. A lot of this has to do with how we counsel people about this and how we sell it to people has been my experience. I actually have in my own clinical practice now managed to manage to talk people into doing this. And I think there's an art to doing so. And I will say that so we've started a nutritional therapy program here at Harborview for folks with inflammatory bowel disease that, apropos to this data, has included the use of EEN in adults preoperatively as salvage therapy, while other therapies are getting started. It's obviously a very self-selected group of individuals who would agree to do something like this. But I can certainly say that anecdotally, we've seen several really strikingly positive results with this. And so that's what I got.
Thank you so much, Dr. Harper. That was an awesome presentation. Going to open it up to anybody with questions on the Q&A. Please feel free to submit your questions. To start, though, a question that I have is going back to the psychology of scheduling pain medications. Do you kind of advise that pain medications be scheduled to try and get on top of patients' pain with IBD?
Non-opiate ones, yes. Yes, I don't know what's stopping us from doing so. I think that there's the safety threshold for some of the things that I mentioned: dicyclomine, hyoscyamine, gabapentin, at the doses that were being described. These are such safe medications. I don't think there's much that's stopping us from doing that. And I think that, again, if we get into the like the difference between somebody coming in and saying, here's your pain meds before you need it, that is a fundamentally different equation. Because I think we've all had that experience, right? Of like when all they have is that they're tethered to the drop-down PRNs that they get on their admission template. What do they start to do? They watch the clock. These are the folks that are literally, they're not getting any sleep because they're on a Q2 3-hour Dilaudid schedule and they're waiting for the clock to hit 1 or 2. Now, to be fair, the stuff that I presented you, I think, is also a very rosy estimate of how we can get away with this. For folks that are very opiate tolerant, very like, this is their 10th hospitalization. To me, these kind of interventions are actually much, much, much more so. This is the prevention. It's like if you have somebody who is not falling into that camp, don't let them get into that camp because there's no need to go there. It's a lot harder. If you have your person who is requesting hydromorphone by name the day they come into the hospital, that's tougher. But I still think there's a realm for some of these interventions. I have seen, I would not schedule benzos, to be entirely clear, but I've seen times where individuals that are like what I'm alluding to, and they end up admitted to the hospital, and it starts to end up, a lot of these times, if I can speak freely, what I've seen from the outside looking in is their IBD is controlled at a certain point. Their inflammation is controlled, but they're not leaving the hospital. And the reason they're not leaving the hospital is because they're on very high doses of intravenous opiate analgesics that they're having trouble getting off of. And these are also folks that, if we go out with the scenario that I'm describing, they're fairly tolerant. Like they're getting these doses and they're breathing and talking to you and saying their pain is under control. To me, this is an interesting arena where sprinkle in some benzodiazepines. because I have seen anecdotally that a lot of those times their pain is also being driven by anticipatory anxiety. And for all our legitimate concerns around over use of benzodiazepines with opiates, understandably, I'm alluding to individuals who are clearly demonstrating that they can tolerate the Dilaudid. I'd be curious if any of you have had that experience. I mean, I think that it's a low hanging fruit. Sometimes I've seen just a little bit of, lorazepam, and like their opiate needs are like 30% the next day.
I personally don't, but I am been very curious about trying that now that we kind of after hearing you present this as an option, and it makes a lot of sense that this might be a kind of a relatively safe way of reducing the amount of opioids that we prescribe.
I think it's reassuring people that you've got them, that you are taking their pain seriously, that you are offering proactive interventions to do so, versus the just, because also the other thing too is that pain worsens when we attend to it. So again, think about the psychology of the nurse coming in at midnight to check your vitals and how much pain are you in? How much pain are you in? Like, well, if I want to get something to make me feel better, I'm going to have to tell you that my pain is a 10. Like, and if I say it, I manifest it, and now my pain is a reality. It's a different topic for a different day, but if you delve into the placebo response literature around pain, in particular, even things like post-operative pain and intentionally giving masked placebos, it's remarkable how much of this is affective.
So Harper, quick question, just to follow up on that. How do you what's your approach to counseling patients about addition of benzodiazepines? Are you upfront that this may be anticipatory anxiety and I'm going to offer this like low dose Ativan or Versed to take as needed?
So truth be told, and this is kind of, this is a little bit of a mea culpa, which I think far too often, I alluded to at the outset, as gastroenterologists, I'm sorry to say, we're all too happy to defer this to the inpatient medic. Nobody wants to touch this topic. And so I think part of this, so to actually your question, I'm not sure that I have a script that I've used before. But I have made this suggestion when some of my patients have been admitted to the inpatient teams. And I think the framing that I have used that they have passed along to the patients is, I think, give things a name. Tell people what it is and why you're doing what you're doing. And if we take the time to explain the thinking, we get buy-in. So it's not, I think one has to be, tread very carefully and not saying, oh, we're just going to treat your anxiety because you're not really in pain. You're just anxious. Not that anybody would say that, but really taking the time to name the relationship and speak to, because a lot of these folks are very open. I've had this conversation with people that we talk about medical trauma and we talk about how being in the hospital, like as ways of actually trying to keep them out of the hospital, like that is such a triggering environment for you. What can we do to keep you out of there? But I think in a similar fashion, it's building that liaison with them of name the issue. Like being in the hospital can be a very distressing place to be and can probably bring up a lot of bad memories for you. And so we want to make sure that in addition to treating pain that you have, that we also help treat any resurfaced trauma or anxiety that you're having too. I don't know, something about it. I just find that if we give it a name, what obviously would not work and would be disingenuous would be to present it as though it's a pain medication, like, oh, you can ask for Ativan when you're in pain, because it's not an analgesic, it's an anxiolytic. And so you call it what it is, but you help them draw the connection between, if you are anxious, that's going to make your pain worse. So if we can take the edge off of that, we will help with that.
Incredibly helpful. Thank you.
Dr. Harper, I also wanted to ask for your thoughts on counseling patients about the importance of early nutrition. Maybe patients who are worried about eating. How would you go about kind of framing the utility of using their gut at the earlier stage?
Yeah. One of the ways, and again, these approaches for sure are not right for everybody. The idea of being on like nothing but boost for days on end does not sound very appealing to me. Like this is not for everybody. I think in a similar fashion, where I've gotten buy-in from folks is by explaining the mechanism that we're trying to do two things here. We're trying to support your nutrition, which is important. And this may, and I emphasize the may, I go over with them that the data is muddy and I don't want to oversell this. It may improve your inflammation as well. Where it gets a little bit harder, and again, it's about, sometimes I find that to get better uptake, you warn them about the negative before they experience it. And you tell them in the beginning, you may notice some of the things people notice during EEN in the first few days is increased bowel movement frequency in some cases, bloating and sort of generalized abdominal discomfort in some cases. And so I warn them about that. And, just acknowledge that if that happens, it doesn't mean that you won't be able to tolerate this. Just give it a couple days and let your body adjust. And in EEN protocols, they are allowed ad libitum intake of clear liquids. So if they're, they don't have to just be drinking Boost all day. They can have like a little bit of fruit juice. They can have tea. They can, depending on how strict the protocol is, they can have coffee. They're not just limited to Boost or Ensure to make it a little bit more tolerable. And even then, if they don't want to do that, I just ask them, like, just give me what you can. Like, if you don't want to do this, just do a couple cans of this a day to support your nutrition. And then really, TPN is really only the backstop if they truly can't do, if they have a mechanical reason that they just can't take PO, then it's better than nothing.
Great, thank you. And then another question that came in is regarding the role of empiric steroids as a steroid burst on admission, especially like in the middle of the night. We don't want to necessarily disturb our GI colleagues with this overnight. Would you advise that it's okay to kind of
give the steroids? That's my advice. Give the steroid. Okay,
give
like
the
this
steroid.
is, your mileage may vary. I'm not speaking for all my colleagues on behalf, but I will just say for me personally, and this is my feeling about this. I'm glad you asked that actually, because I think there's so much of this, like, I don't know. I see with our GI fellows sometimes too, there's this like trepidation around steroids. Like, if you give a dose for a day or two and you find out you shouldn't have given it, oh well, then you need to stop giving it. Like, it's but far better you get the ball rolling than like 3 days goes by, their inflammation is through the roof, and then now we're starting steroids, because that's 3 days where they've had no effective medical therapy. Some of the common reasons I hear why people feel hesitant, well, we haven't ruled out infection yet. My feeling, don't care. Like, if they have C. diff, if they have UC and they're coming in with a hot UC flare, if they test positive for C. diff, you need to do both. You treat the steroids, the UC, you treat the C. diff with vancomycin, period. Like, but they still need the steroids. Studies have actually shown that in folks with UC with concurrent C. diff, delayed medical treatment is associated with worse outcomes. You treat the UC first, and then you can deal with all the rest of the stuff later. And at the end of the day, if GI comes in the next day and is like, you gave steroids, oh my gosh, they will have gotten 1 dose of Solu-Medrol. You'll be fine. Just give the steroids.
Awesome. Well, thank you so much, Dr. Harper. That was a fantastic presentation. Again, the slides will be available to those afterwards.